Do I sound
No, there's
awful?
no audio problems. I'm kidding. You sound good, mate.
That was a general comment, right? You should have said you look awful. But yes, so from a background perspective, I have been the CIO of CPCA for about 3.5 years, and the reason it's relevant is that I spent a lot of my time on advocacy with the HR vendors. We do have the opportunity at least once a quarter to meet most of the senior management, the EHR firms. We meet once a quarter with NextGen, once a quarter, if not more frequently with the clinical works, and we meet with Epic and so on. And it's also my responsibility to manage and maintain the user groups. And from a context perspective, in California, we have about 140 odd FQHCs, which are under the purview of CPCA. Those are members. And the general distribution of EHRs from so that you're aware and have some context is not in any particular order: eClinical Works, NextGen, and Epic. And Epic started off being lower, and has significantly started making big penetration in California, especially because Kaiser, right, is in California. So, and that is all kind of interesting because there is, this is a dense slide deck. As Josefa mentioned, I have the ability to just keep going on and on. And this in particular is a topic I'm extremely passionate about, because it ultimately impacts the delivery of care. So you will have the deck, of course. There are some 30 odd slides. I plan to go through maybe half of them, if that. And I won't go through like the wonky stuff. You can go to the ONC website. There is a lot of webinars and presentations which go through a lot of detail around the 21st Century Cures Act. And I'll try and focus my presentation today more in terms of context and background and timeline and what you should anticipate and so on, right? And I mean, for us or for you, depending upon who's in the audience, right, this is like the holy grail, I have been chasing, so to speak, in my career. And I've been in health IT, for more than 15 years. Just from a background and context perspective, let me just change the slide here. Okay. So yeah, from an we will, I will stay away from, the nitty-gritty details of the actual act. It's available in a lot of detail, but I'll try and focus more on background, and we'll talk a lot about information blocking because that's very pertinent, to what we all do in the FQHC world, and then a little bit about pediatrics because, that's an interesting change in terms of how data can be accessed and what that means, at FQHCs, because all of us, right, see pediatric patients. And there is also a behavioral health impact, which applies to us as well. So with that said, right, I mean, this goes, so Obama was the one in 2016, right, as part of, the team, the healthcare team was really thinking about Obamacare and how to implement it and how to reduce the overall cost of care, right? And I mean, the biggest thing we're going to talk about today, right, is the challenge that has historically existed in the healthcare system in general is the lack of transparency, right? And the lack of transparency allows organizations to charge whatever they want, and that consequently increases the cost of care and so on and so forth, right? So, I mean, you have all been, I'm sure you've heard of all of that during the Affordable Care Act and so on and so forth. So, so for me, at least, or, for a lot of us in health IT, this goes back a little bit more, right? So I started my FQHC career at the Primary Care Association in DC, and we were in the midst, we actually deployed an EHR, eClinical Works in that case, across DC. I mean, they got a grant and they implemented, and it was interesting, right? That even, so the whole idea at that point was, to get rid of information silos, allow for patients to move between practices or FQHCs. And yes, there tends to be some level of healthy, in some cases unhealthy competition between FQHCs, but there was really not a way, right, to move data. And at that point, Google got really interested in this concept, Microsoft got really interested, and this preempts, right, all of this. But that is what the ONC was thinking about back then. And Farshad was, I'm not sure if you remember, in 2010, the ONC lead, and then he subsequently left and started a company called Validate, which is actually based in Maryland, where I'm located. But regardless, right, there was a lot of formative thinking happening with that group. They all knew FQHCs, which was kind of intriguing. Farshad knew FQHCs really well because he came from New York, and he understood how FQHCs work and so on and so forth. And I mean, I live close to DC. I actually had the opportunity to go and meet Farshad, and they were beginning to, back then, right, start thinking about how all of this is potentially going to work, right? And the whole idea, or the whole challenge always was, the data belongs to the patient, and why, how, and in what way are we going to come up with a way to provide data to the patient, right? And if you think about it, it all boils down to, unfortunately, in all cases, right, money. Because the providers of information, which is the EHR vendors, right, from an approach to the economy or their capitalistic instincts, right? I mean, good or bad, right? We live in a capitalistic society. I mean, if we were in a socialized country with socialized medicine and had a single EHR, and I'm not advocating one versus the other, potentially you could all have access, right, to a single record from a healthcare perspective, or longitudinal care record that I in my career have been talking about for 10 or 15 years. So rather than trying to convince, right, the EHR vendors to interoperate, and in DC it was not an issue because they were all on the same EHR, and even the same EHR vendor could not interoperate at that point across different instances. And then they came up with the technology called AACHC, yada yada yada, right? So the way the ONC tried to circumvent this whole lack of interoperability was to introduce the concept of the National Health Information Network, the health information exchanges, the regional health information organizations, or the RIOs, and DC had one, and all of that, unfortunately, despite a ton of investment, failed, right? Because we were trying to work around the issue that the EHR vendors inherently didn't want to communicate with each other. So, the first implementation, so to speak, of a way to give patients access to their data was through a technology called a PHR, or a personal health record. Then Google had a tool called Google Ward. Microsoft came up with its own technology. Didn't go ways, because the burden was being put on the patient, right? And we're going to talk about patient burden as well today, because they're a key constituent, right, as from an impact perspective with this act. And the notion was, right, and it finally ended up in meaningful use with CCD and CCRs, that you could go to your physician, your specialist, your primary care vendor, you would give them a key fob, encrypted key fob, they would download, your records, you would go home, you would plug it, connect it to some website or an app, and you would start consolidating the data, right? Make it as difficult as possible for the patient. And the providers were, of course, really worried about liability, right? Because they don't want the entire documentation of the record to reside with the patient. So that went on for several years, and then 2016 came about. So I'm talking about a timeline somewhere around 2010 to 2016, where a lot of this gestated. And finally, right, because of Obamacare, there was a bi-party or a bipartisan approach where everybody, was focused on everything aside, empowering the patient with their information and reducing the cost of care, that this started moving. But, also remember that we're in 2021, and, just have that context that, we are just beginning to talk about the implementation of this 5 years later, and all the cool things this Cures Act is supposed to do, right? I mean, it'll be interesting to see how they manifest themselves. So that's, a high level background from a business perspective, from a marketplace perspective, because, if you think about it, let's just take the idea of an EHR, right? And before meaningful use, there was no context of a patient portal, right? And for all the complaining that EHR vendors did around meaningful use, because they were never asked to comply from a regulatory perspective, they also got to generate a lot of revenue with ancillary products like a patient portal, right? So, suddenly, if I'm an EHR vendor, I'm used to now charging you $99 or $59, whatever it is per month per provider. And that's a very nice, right, revenue stream, where you don't have to really do anything much, right? You buy some additional equipment, you have already built the app, you have to refine it, of course, over time. and you're depreciating the infrastructure and you're getting this hefty revenue stream, and if the organization adds more providers, you keep getting more and more money, right? So the last thing you want to do is to allow a third party to develop a patient portal which hooks onto your data and maybe does even a better job, right, of displaying and interacting with the patient than you do, right? And that's why we are still somewhat stuck in this quagmire where the quality of the patient portals, right, is suboptimal, and they are not really designed from an ease of use perspective for the patient. They are just designed to generate data and throw it at the patient, and don't really empower them, right, to do anything with it. And I say that because there is also now a notion of something called actionable data that is required by law under the 21st Century Cures Act. So we covered the basics. We are now up to 2021, right? And this is, again, a high-level overview of the 21st Century Cures Act. I would, especially pay attention to the right hand, or I don't know what hand that is. I apologize for you guys, but the key stakeholders, right? I mean, we represent a lot of it, right? We are patients, right? We work in a hospital or a healthcare environment. We interact with providers. Some of us, like me, right, interact a lot with health IT developers. And then, the bigger notion, right, we are trying to move to higher transparency and reducing the total cost of care delivery in this country, because on a benchmark basis, we all know the cost of care in this country versus the quality of care we deliver, right, is not that good compared to other nations in the world. So that's the real and the somewhat higher level concept or construct behind the act. But it's very intriguing, right? Because if you read through, and the left hand side is actually verbiage from the rule, I would highlight, or if you have a printed copy or thinking about this or reading it again, right, look at some of the interesting words that they have added, right? Innovation, right? So let's talk about innovation for a second, right? The fact that I'm an EHR vendor and I have developed a closed box, right, on the cloud, and I'm not going to let you interact through any open application programming interfaces. I mean, what is going to do, right? That's going to stifle innovation, and that is going to prevent any third parties to develop tools which could potentially do a much better job, right? Because I mean, the EHR vendor cannot be an expert in everything, right? I mean, they had some core expertise. Now suddenly, right, they're a portal expert, they're this expert, that expert, and they're trying to distinguish, and they're trying to sell you everything as a package, right? So the innovation piece is all about, I mean, look at what happened when the Apple marketplace opened, how innovative that concept was, right? Or now there is a Google marketplace, there is an Amazon marketplace. And you have this ability now to go to the marketplace, look for a certain thing that you're trying to do, download it and latch it on, right? I mean, it's much easier now because the implementation of those kind of technologies in the marketplace are standards based. I mean, there is still a lot of anti-competitive behavior, right? Because you can download like a Google marketplace app in the Apple marketplace app, and that in itself is a big point of contention. But that's kind of where, right, the ONC is leading us towards. So innovation is a big part of it, right? I mean, hopefully, it means simple things like, our wearables can interact directly with the EHR and the provider. Your Fitbit can interact with the EHR natively, through an app without having to talk to the provider, and the provider gets access to dynamic data. Then it runs, the tool runs, I don't know, AI on it. And, it provides information to the provider on an exception basis rather than overwhelming the provider with data, right? And those are all the things we're talking about and thinking about in anticipation of this rolling out, fully, and I don't know when that is going to happen, right? So innovation, competition, right? We talked about competition, so let's talk about competition a little bit more so that everybody has some context, right? So we are quite privileged as FQHCs that we were probably the first wave of ambulatory organizations that went live on an EMR, right? So we are privileged, we are fortunate. I'm not trying to say that that went well, right? In health IT, everywhere, any folks in the room, right? We all acknowledge that, I mean, this was supposed to improve a lot of things, right? It was supposed to improve the quality of life for the physicians. It was supposed to improve the integrity of data. And, we went into this whole electronification of the patient records with the idea that, okay, even if, right, the end game is that the providers are at the base, right, same, right, if not, more happy, we're in a good place, and we are doing this because, it was all meant to be ultimately, right, about the patient. The patient should have access to the data, quality of care, all the metrics should improve over time, and so on and so forth. So a lot of those things, right, didn't happen. And what started happening in the market was, nobody had heard of Epic, right? I mean, about 10 years ago, right, they were working with Kaiser. Kaiser was essentially funding them, right, as a research organization. And they came up with this product which allowed them to consolidate all the modules within a hospital. And guess what happened, right? Suddenly, even though it's an extremely expensive tool, very complex to implement, it started getting a lot of mileage in academic hospitals. Now it's in integrated delivery networks and so on and so forth, right? So if you look at the history of how Epic evolved, right? Because I mean, we are closely following the penetration of Epic in California, right? And we talk a lot to our members to really understand what is motivating them, what is driving the change, and so on and so forth, right? And it's very similar to what happened in the market. So the penetration of Epic in general completely caught, the ambulatory EHR vendors and the hospital EHR vendors like Cerner off guard. And they had to develop a competitive threat. They had to, for the first time, they were forced to collaborate, which is not in their nature to do. And they started this interoperability based nonprofit. And then, Epic didn't want to play with them, started its own nonprofit. So, we gestated two different nonprofits focused on interoperability because everybody knew the Cures Act was coming. And still nobody wanted to talk to each other. And they were only doing it, right, for market forces perspective. They wanted a way to talk among themselves, but not with Epic. And Epic didn't want to talk with anybody else, right? So Epic developed this positive reputation for being interoperable, which is somewhat of a misnomer because what Epic quickly figured out initially was that all instances of Epic can talk to each other. Doesn't make you interoperable, right? It's actually a way to be even more, anti-competitive. And Judy was called up on that, and et cetera, right? But she didn't do anything different than anybody else did. But the market environment was such that the EHR vendors suddenly had to come together and collaborate, which they had never done before. So they developed a nonprofit, they developed standards, and they started interoperating. And that's how Care Quality and Commonwealth came about, right? And this is how we are here today, right? From a 24 Cures Act perspective. And the last couple of years, right, the drumbeat became so loud that Epic had to come, Care Quality, right? And both organizations had to come together and say, okay, we have to make data interoperable across the board, right? We will all play nice. Now it's slowly beginning, to be implemented. I'm not sure how many of you have that implemented, right? But these people understand, right, that the Cures Act is coming. For the longest time, Epic was the big man in the crowd. They could do whatever they want, right? And that's what happens where everybody tries to be a monopoly, right? That's the sheer nature of how we work. But now they see, right, you can only go so far, right? Because, I mean, if you talk to a resident these days, and 95% probability that they're coming from a hospital, right, where they have been exposed to Epic. If you ask them what they like about Epic, they will not say, and I'm telling you this because we have surveyed this, right? The first response is not because they like the user interface. Their first response is that they love the fact that they can have access to data from the hospital when they're in an ambulatory setting. Now, is Epic in some way facilitating that? No, they really want you to adopt Epic slowly but surely in the ambulatory setting too. But it's not something just they do. Everybody would have tried to do that. So hopefully, right, is the Cures Act eventually going to mean beyond innovation that we will have a broader stratification in the market? From an EHR perspective, I don't know. We are just coming from a mass wave of consolidation. We only have, I would say, 5 viable vendors left from an FQHC market perspective, right? So things have gone, when I started, there were tons. We didn't like that fact, right? Now it's come almost full the other way. And that's not a good place to be in, right? Because you just have a handful of vendors who are, again, demonstrating monopolistic tendencies, and then they're not going to innovate and so on. So hopefully the 21st Century Cures Act, right, will negate some of those behaviors. So this act, right, talks about things like standards. They talk about transparency, right? I mean, it goes to the basic notion that none of us really have the way, right, to shop for our care and see where we can get the best quality care at the cheapest price. And, this is supposed to facilitate that over time. And then, they're not forgetting the fact that all information exchange has to be secure, right? I mean, you hear about ransoms all the time. Now, this is a new paradigm, right? Because the patient will have easier access to their data. Providers can easily exchange data. And I'm not sure when these acronyms or adjectives will actually come into being truly, because there is going to be a significant amount of pushback, right, from these organizations, which are billions of dollars in revenue. But slowly but surely, things are beginning to move, in the right direction. And you should just anticipate, everything, as you can see, moves in 5-year, 10-year tranches. And, that's what you should anticipate. So right-hand side is the goals for me, patients, doctors, and so on. And I would pay special attention, right, in terms of things like, standards, because we're going to talk about APIs, we're going to talk about FHIR in just a minute. The anti-competitive behavior that you can call, or the ONC can call, a vendor on. And, ultimately, then the whole idea is these things take root, then innovation will take place. So great. So how did we get here? Right. I mean, just think of it even now, right? If, like, I have a primary care provider, periodically, I see a couple of specialists. My kids, see a different primary care provider. And my children, one of my children actually sees a specialist, right? So, I mean, I would say 2 out of the 6 use the same EHR. The remaining 4 use different, right? So I have to look at prospectively 5 different patient portals to manage care for my family, right? And if you have extended family, grandparents, siblings, you can just imagine how big a mess, the EHR vendors have created, just so that, more licenses can be sold. And, that's just how things work, right? So, the health information exchanges was never, I think we all knew that this was not going to be fundamentally the way, to address the issue that we didn't have access to a longitudinal care record. If I go multiple places, I don't want to carry a key fob. I want to go and see my primary care provider. The primary care provider sends some kind of a ask, to my hospital or whatever, right? And the record comes in, it's all standards-based, integrates, and we both have, a look into my contiguous record, right? Doesn't happen right now. Slowly will start happening, right? But the health information exchanges, nobody was sure back then. And the NHIN goes back to Bush days, right? Nobody was sure that this level of legislation could actually be pushed through. So, it's interesting to see how this is all going to go. And that's why, right? I mean, if you can just exchange data between 2 databases freely, there is really no need for a centralized repository, right? You can build like mesh networks. You can do a lot of things from a security perspective. But the health information exchanges, and the reason they failed, right? Most of them failed, was because the health information exchange was only interested in developing an architecture, getting funding, and asking us, including FQHCs, to send data to the health information exchange without a really viable use case or a way for them to send data back, right? The whole idea, if I'm sending data to you, then I expect you to send me back data about that patient wherever else you got it, right? And you have to look at a portal, not happening, right? So I think the future of HIEs, right? I mean, at some point, there probably won't be a need for it if we can go down the path of a completely interoperable healthcare economy, but we'll see. The health apps, right? So, we talked about the fact that, I mean, we're all used to apps at this point, right? And, you can creatively think of so many of them yourself. What if you don't like the user interface of your EHR, right? And the EHR vendor, is allowed under the Cures Act to share the schema with third-party vendors. And, the API hooks, yes, schema, they probably won't show even now, and you can hook up another UI, or you can take a module within the EHR that you don't like. Oh, I hate the referral module. Oh, company Joe Schmo has a generic module that I can, plug and play. So we'll see, how many years that is going to take. But, that is a big, big threat, right, to the EHR vendors, where they could just then charge for hosting and a database schema. And then, the interesting part is EHRs are under the purview of HIPAA, and the apps are under the purview of the FTC. So that has to get flushed out, because as you can understand, everybody needs to follow HIPAA, especially if you're going to start exchanging data about patients in a marketplace, and it's going to flow freely and so on and so forth. You don't want a situation where they're dropping cookies like Google does, and next thing Amazon listens in and starts suggesting stuff you should buy. So so that those are still some of the challenges and some things for you guys to be aware of. But the underlying idea, right, again, is to spur innovation, and the big focus, of course, is the patients, developers, and hospitals. It doesn't have to be hospitals, right? That's how they phrase it at the ONC level, but any healthcare setting, including the ones we work in on an ongoing basis. I will skip a lot of these things, because they are available online. But the things to focus on, right, is what is it that the ONC is trying to. It's actually quite amazing how much effort has gone into this legislation. If you take the time to look into, all the parts of the legislation, and, how much wheeling and dealing happened, and all the different stakeholders had a posture. It's like anything, right? Gerrymandering that happens, in the Senate and the House. But it's still pretty neat to see all the things, that they have managed, like, for example, they had put in the first bullet, right, talks about the word they had initially, in the initial version, talked about access to data. And then they're like, no, we actually meant not just access, but exchange, right? And then they talk about not just unidirectional access to data, bidirectional. So they keep clarifying to the point where it's a pretty robust act, which I highly encourage you guys to read through, or go to the ONC website and look at the webinar. But some things have come out because, they were too descriptive, and they were, they could be misconstrued deliberately by the vendors. So, the ONC has gone in and refined the language, but this piece refers to the whole idea of about providing access. All right. I mean, they changed the word access, not just access, but it's exchange. So, it's intriguing, right? You might read the first bullet and say, this is very interesting. They removed the word securely and efficiently, right, from the final act. And it has to do with, right, the gamesmanship these EHR vendors are expected to play, where, the more you narrow things down, they could say that, well, our processes are still not efficient, right? Or we are in an app marketplace, which is governed by somebody else. It's not required to be secure, so we're not going to transmit data, right? So, what the ONC basically said in this case was, it's a given that it has to be secure and efficient. So we're just going to remove the word so that there is no opportunity for organizations to do information blocking, right? And the last bullet talks about bidirectional flow of data. And, we are used to unidirectional a lot, right? The labs and radiology and so on. But more and more, this challenges us to exchange data bidirectionally. This particular one talks about use. And again, I will skip that piece, and and we'll spend a good 5 or 7 minutes talking about information blocking, because this is the piece on the left is more descriptive in terms of what the ONC has to say. And there is a subsequent set of slides where I talk more generically about information blocking and practical examples. So, I'm going to skip this for just a second, and then, we can talk about information blocking a lot more. So this is very important, right? Impacts all of us. It's real, it's happening, right? It's still within, right, the duration of the current administration. So we all feel quite optimistic that, we will get to see most of these through. I don't know what, I mean, it's not, I don't know what will happen with the next administration, right? But then the lobbying starts again. People with different perspectives come on. Maybe there is continuity. I don't know. But, we are encouraged by the fact that, the changes that are being implemented as part of this act, right, have this literal timeline. There was an extension put in because of COVID, but this is the latest timeline as per the ONC website. All right. So a couple of minutes on updates, right? I mean, they have changed criteria, they have revised them, they have added new criteria. I'm just going to talk about, the details are maybe not that important, and, you can read them up, and they're fairly, straightforward. But I think, the ones worth talking about are API, and I'll talk about that in a second. So there is a new standard. We used to follow a standard called CCDS for documentation, and that has been replaced with the new standard called USCDI. And again, it's pretty easy to understand. There is a website for healthit.gov where you have the USCDI 1.0 and the USCDI 2.0 standard. And of course, the EHR vendors, right? If you think about it, they have to confirm. It talks about how you document, how the SOAP note is written, where the metadata is stored, right? Where the security tags have to go. What do you have to do for pediatric data? What do you have to do with behavioral health data? So this has an impact, right? More in terms of what the EHR vendors have to do. And of course, right, downstream in our ability to document data or access data that we have not been able to before. So let's talk a little bit about APIs. If you don't mind, please do look up later if you're interested, the US CDI 2.0 standard. And, we'll talk about security tags a little bit more, because behavioral health data and pediatric data is under the purview, of Cures Act 2.0. So yeah, the top of the slide, provenance stands for metadata. I don't know why they use a fancy word like that. So, it's basically who is, adding data, who is removing data, keeping track of that from a metadata perspective is called provenance. And if you want to look at, what they say about pediatrics clinical notes, it's all out there under the USCD 2.0, standard. And that's interesting. They're also now changing the word EHI, which they used to use, to EPHI. So it's more encompassing, and it also is beginning to incorporate the concept of security and HIPAA, right? So, as far as this is concerned and us go forward, the word EHI is going to disappear and it's going to be replaced with EPHI, even though when they implemented or started developing the act, they still referred it to as EHI. But, big difference and big change in thinking, which is all positive for us.
Rupak, we have a question.
All right.
So
yeah,
when it
please.
comes to information blocking, what are the providers liable for, under the Cures Act, especially now that you mentioned HIPAA? And then how FHIR is going to be, what role FHIR is playing into this whole Cures Act?
Yeah, so bear with me for like 2 minutes. I'm not sure who asked the question. Let's talk about information blocking after APIs. And, there is many different ways, and a lot of the things we still even, haven't thought about, right? And they're going to get figured out. Like, for example, you can't restrict access for a patient-to-patient portal, right? If you do, that's a violation of this act, right? It could be as simple as that. If you are using a non-certified EHR, that could be a violation, right? A lot of the burden falls on developers and the EHR vendors, but, we're all going to be much more liable, with these matters. So let me just talk quickly about APIs, right? So APIs, it's an application programming interface. In the old days, right? And I know I'm old, but, we used to use a language called HL7. It's a very basic language, and that's what we used to use to exchange data between systems. So, if you were using Dentrix for your dental system, and you were using, I don't know, NextGen for your EHR, and you wanted a way for demographic data to flow back and forth, we would have these interfaces like an SIU interface, which is a scheduling interface or a claims interface or a demographic or a interface, and, information was flowing back and forth, right? So now, technology has evolved so much that now we have a notion of application programming interface. It's basically code and allows bidirectionally, right, both parties to expose some artifacts based on standards, and information can easily go back and forth, right? So it's a much more reliable, standardized, robust way of exchanging information. And this again is significant. And the reason why, so there is a certification process now, right? Just like Apple doesn't allow you to put a rogue application on its app store, right? This is going to be similar, because you just can't have something insecure or not working properly and so on and so forth. So that is going to slow down things a lot, and the EHR vendors are going to take advantage of it. But it's meant to be transparent. The fees are supposed to be, reasonable, and everything has to spawn competitiveness, and we'll see how that goes. So this word, right, FHIR, as we call it, it's actually FHIR, is the next version or the new version of HL7, right? And it's based on APIs. Among the current EHR base that we interact with in the FQHC world, probably the strongest implementation of FHIR and the marketplace. And I'm not advocating for any vendor, I actually the opposite, given my role and belief system. But Athena one product, right? They just came to the market with a different, it's all about money, of course, right? And Athena was really a billing company with an EHR on top, and they are looking to come over and take your billing. And essentially, there is a lot of money they can keep, right, in that. And, then they essentially give an EHR. But to them, right, the notion of having a marketplace was not a competitive threat. So they were one of the few, and one of the few still, to launch a highly competitive, elegant Athena marketplace, where you can, I know of entrepreneurs, 3-5 people came up with a great idea. The first one they get to launch it in is Athena, right? It becomes like the place where they can showcase it to prospective customers, and then other vendors have to oblige. But this FHIR piece, right, is going to be a big part of what happens go forward, with the Cures Act. So something from an interoperability perspective, you should probably become, very, very familiar with. So I won't,
Rupak,
go ahead.
you have 5 minutes left.
Okay, so let's talk about information blocking. So for the next 5 minutes, right? So practical examples of information blocking. The word tells you, right? You're not allowed to block the flow of data, especially when it applies to a patient. So you cannot prevent an organization to move their data from one EHR vendor to the other. There are actually a couple of EHR vendors we use who actually got penalized, right? Hundreds of millions of dollars for doing just that. So any EHR vendor that prevents their data, your data, right? It's not your data, it's not their data, it's the patient's data, right? That data cannot be held hostage by an EHR vendor. Now, the definition of an EHR vendor is going to continue to expand, right? It's going to include apps and so on and so forth. So now these are two, right, distinct things to think about as a provider. And if you think of a provider as a provider of services or a practice, I gave you the example of a patient portal, right? And then it's going to be it is going to be your responsibility to make sure that all the lab results for the patient come directly into your EHR. And if they're missing, and that means if it impacts the care that is being delivered to the patient, then in some way you could be held liable. Now, all of these things, right, are going to be flushed out. But there is definitely a non-compliance impact on providers, but I would say the most is on health IT developers, app developers, and the EHR vendors. We talked about this. There are a bunch of exceptions, of course, which got lobbied and put in, but still, it's still a very strong suite of acts that you should look at. Pediatrics, right? So it's important because this is the first time that if you have interoperable and open access to data, this act is going to potentially allow people related to an adolescent, an adoptive parent, a guardian, a foster parent, right, to have access to the child's data. And it's a big controversial item right now because, yes, it will empower the child to have access to their own data, right, empower them as needed. But then the data can be manipulated. How much do you trust a guardian versus an adoptive parent versus a foster parent? What happens if you move from one foster parent to another foster parent? So that is also another practical implication that you all need to think about, that there is certainly an impact from a pediatric perspective. It is going to get flushed out. I mean, the American Association of Pediatric Care has started putting out some position papers and expressing some concerns and seeing how this all kind of comes about. But just like anything else, right, it'll take a little while, a year or two, just to kind of stabilize and come through. So, and you have, there is an AMA reference, there is a guide for fire on the right hand side, right? This is actually we wrote a position paper in CPCA about this act, because this is huge, right? If you're in a health IT, so if you're interested, take a peek. And yeah, that's it.
Thank you so much, Rupak. Do we have any questions?
Sure.
I know that we have like 3 minutes left. All right. If any question comes up, as I said before, we have been partnered with them. Please reach out to your HCCN coach and we will put you in contact.